Shall I start?
Just a moment.
Okay.
Yes, it's a start.
Okay. It's really honor and privilege to introduce Dr. Fujiwara. So I will give you a short introduction to the audience today. Dr. Fujiwara received his PhD and MD from the Tokyo Medical and Dental University and the Master of Public Health from Harvard School of Public Health in 2006. He accomplished postgraduate research at National Center for Child Health and Development, Harvard School of Public Health, and the University of British Columbia. Since 2008, he moved to Japan to serve as Chief of Section of Behavioral Science at National Institute of Public Health. From 2010, he works as Head of Department of Social Medicine and National Research Institute for Child Health and Development in Japan. Since 2016, he is appointed as professor at Tokyo Medical and Dental University. His research interests are child abuse prevention, mental health, biology of social behavior, life course epidemiology, and social epidemiology. So all important areas in preventive medicine and public health. From 2020, he served as associate editor of Child Abuse and Neglect. So I will invite Dr. Fujiwara for his wonderful talk. Dr. Fujiwara, please.
Okay. And okay, all right. So sorry, let me share my slides.
원세별 씨, 그거.
Yeah, you can share the screen. So.
Okay, now it's coming. Okay, so thank you very much for giving me this opportunity. Can you see this right?
Yes, okay. Great.
Okay, thank you so much. Thank you very much for your kind introduction to me, Dr. Hong, and my friend, Professor Joan, invited me this talk, and we are kind of like sibling disciple of Professor Kawachi at Harvard. So I can't deny his invitation. Then I have done lots of research on the child abuse and life course epidemiology. So then concerning about the recent unstable situation in the world, I picked this topic at the post child experience, focusing on abuse, domestic violence, and war. So let me give the time to talk 40 minutes or less, then let's move to the discussion. Okay, so this is the outline of my talk. What is the post-child experience study? How much ACE affect on health? How ACEs affect on health? And war as an induction of ACE and conclusion. Okay, let me begin with ACEs study. I guess this is quite famous study, and then this study has been cited to 10,000, more than 10,000. So, let me review what is this advanced child experience study. Okay, the doctor, if you have this kind of obese patient and she joined the obesity treatment program, but if she continue, she cannot stop eating. What is the cause of this obesity? Any thoughts on this? We can say lots of risk factors on obesity, like how do you say, stress or genetic, family background, anything. But Dr. Ferretti's patient saying that she said that she was experienced sexual abuse in childhood, and on the day of the incident happened, she said that she cannot stop eating. So this is the beginning of ACEs study, and meaning that adverse childhood experience may induce some adult disease. And I'm going to explain why later, but this is what the ACEs study. And this guy, Dr. Ferretti, is the physician of internal medicine in California, and he investigated adverse childhood experience and lifestyle and adult disease in California, and he studied this kind of childhood experience in a questionnaire and linked with the medical health record for up to like 13,000. And then he got a quite good response rate, 71%, and reached 9,500 participants. Mean age 56. Then in this the very beginning study, the concept of adverse childhood experience were focusing on psychological abuse, physical abuse, sexual abuse, like abuse. Then family drug, alcohol abuse, family mental illness. This is like a family mental health background, family dysfunction, and mother treated violently, meaning witness of domestic violence, and family member in prison. So he counted the number of adverse childhood experience, then mostly known experience, but like a 40%, 30%, 40% experience had reached one adverse experience. Then some cases of 4 or more adverse experience. Then as you may know, if we find some dose response association between ACE and disease, we may feel like this may suggest some causality. So he did it. And if we pick the lifestyle, like smoking, obesity, non-physical activity, that kind of stuff, and he found that having a higher number of adverse experience, more likely to be smoker, obesity, no physical activity, depression, and attempt suicide. And specifically, those who are having 4 or more ACEs showing the quite high risk for this kind of lifestyle. And alcohol, again, drinking, very beautiful dose response association, and for illicit drug use and inject drug use, and having 50 or more sexual intercourse with partners. And for that reason, ever had a STD showing the high risk for those who have a high ACE lifestyle. Then these kind of unhealthy lifestyle induce disease. Then the risk of developing ischemic heart disease, cancer, stroke, chronic bronchitis, and diabetes mellitus increase, especially for those who have 4 or more. We can see some dose response, but recent research are focusing on the highest end, 4 or more ACEs. Okay, then even more accidents can happen. Probably those who experience ACE more likely to take a risk than skeletal fracture, hepatitis, jaundice. This may be due to injection. Then poor, fair or poor self-rated health. The self-rated health is quite important outcome because this one linked with actual life expectancy. Then they actually did it. They compared the life expectancy by the number of days. Then they found that those who have 6 or more ACEs live 20 years shorter. This is quite significant range, isn't it? So based on this kind of finding, CDC saying that having an ACE is very, very important risk factor for the disease. Then they call it the ACE pyramid. Those who having ACE have a disrupted neurodevelopment. This induces social, emotional, cognitive impairment. And this kind of impaired cognitive function induce adaptation of high-risk behavior. Then, based on this kind of unhealthy risk behavior, disease, disability, social program occurs. Then, eventually, lead to die. Okay, this is a story of a study and how much ACEs affect on health. So, CDC in US calculated the burden due to ACE. Having an ACE, more likely to let the people more having a depression. In other words, if we reduce the adverse child experience, we can reduce depression. How much? 44%. For COPD, 27%, because people with adverse child experience more likely to smoke. Asthma can be prevented. Kidney disease, stroke, coronary heart disease, cancer, diabetes, and obesity. So these adult disease are obviously multifactorial, but as you can see, childhood adverse child experience can be considered as a root cause in the lifetime. So social epidemiologists like cause of causes. In horizontal perspective, the root cause might be some policy or law, but for the longitudinal perspective, in the timeline perspective, childhood is the root cause. So reduction of ACE has a huge impact to prevent health, to prevent disease, and to reduce the health economy. Then including health risk behavior, smoking, heavy drinking, and actually even more, if we reduce ACE, we can improve unemployment. We can improve education, meaning that we can reduce the number of who cannot graduate high school or no health insurance in states actually. So then actually even more, I think that if adverse child experience impact on adult disease in the middle age that Verity found, this might continue to older age. So, and then in Japan and maybe Korea too, we have a facing older age society. But in other words, we are top runner to show the evidence of how to deal with the age society. So we did lots of research, and among them, we investigated the association between adverse childhood experience and adult disease among older people in Japan. So there is a big data, nationwide study for older people in Japan, JGIS. They, in this study, like 20,000 participants reported the adverse childhood experience. All of them are 65 years or older. parental death, parental divorce, parental mental health, witness of domestic violence, physical abuse, psychological abuse, and neglect. And there are several outcomes can be set. And today I picked 2 outcomes: higher level of functional disability, meaning instrumental ADL, like those who can read, take a walk, take a bath, and intellectual ADL, like people can read newspaper, books, something like that. And social ADL, older people can talk with young people, something. This kind of daily life activity is important for healthy, happy aged society. But having age might deteriorate this kind of higher level function disability. And dementia. In Japan, we have a public long-term care system, and then every 3 years we assess the cognitive function by some trained care provider. Then we can link with this dementia assessment with adverse childhood experience. Okay, so this is a conceptual model. Sorry, this is a bit shaded. So we are focusing on this ACE and higher level functional limitation. But even the people experience abuse or not may be influenced by childhood poverty. There's a strong link with poverty and abuse, and those who experience childhood poverty may have a direct impact on older age functional limitation. So it's confounded, and there are several mediators like adult health, adult behavior and health status, and social economic status during the lifetime. Okay, so these kind of things considered as, both confounders and mediators, and simply saying that in the final model, we found that having 2 or more adverse child experience 1.5 times more likely to show poor high functional limitation among older adults. So we found having ACE last long, and even 50 years later, after 6 years old. Scary. And dementia. Again, this clearly showing that having 3 or more ACEs 2.2 times more likely to develop dementia in the same sample, adjusted for age, sex, education, childhood SES, and height. Height is used as a proxy of childhood nutrient status. Okay, this is done by my assistant professor, Dr. Tani. Okay, so until in this moment, you guys may feel like, can they recall correctly for the adverse childhood experience? And the answer is acceptable, maybe yes. And why? This is the study done by the famous birth cohort study in New Zealand, Dunedin cohort. And then this guy, Ruben, analyzed the actual prospective assessment of abuse, neglect, parental loss at 3, 5, 7, 9, 11, 13, 15 years old. And as this is the, I would say, followed up to 35 years old, and at 38 years old, and then ask them whether they have abuse or not, whether they have lost their parents or not. Then they counted the number of A's and analyzed the correlation, and it was good, 0.5, and It's not very high, but not very low. So I think that we can correct the adverse child experience in a recall setting. Okay, so why ACE affects on health? So to talk about the mechanism or why ACE affects on health, I think I would like to review the three famous theories: attachment, DOHAT, and trauma. And each theory suggests some importance of mechanism on ACE. For attachment, deprivation; for DOHAT, nutrients; and for trauma, importance of a threat. So, as you may know, attachment theory is developed by British psychiatrist John Bowlby, and he investigated the juvenile thieves and found that those who experience the separation from primary caregiver, mostly mothers, more likely to become thieves. So the primary caregiver loss is very important for the future development. So based on this kind of his study and assessment, he developed attachment theory. So attachment theory is that the people need some secured situation to do something, to specifically to investigate something, to believe some people, to interact with people. So this kind of a basis of mind developed through the very secured interaction with primary caregiver. That's what the Bowlby found. And I say that most of the psychological developmental psychological foundation is developed based on this attachment theory. And DOHAT, this is this hypothesis developed by David Barker, also British epidemiologist actually. So his hypothesis is like this: during in the fetus, in a poor diet, and if during the fetus the nutrition is poor, then predictive adaptive response occurred, meaning that the program of safety phenotype, even in after delivery, there might be less nutritional environment. So we need to keep energy. So then the deliverer does a low birth weight, but there is a gap between the predicted environment. Actually, the reality is rich nutritional environment, but safety phenotype already occurred. Then that is why people became obese. So this is done by some mice and same gene, but different nutritional situation during pregnancy. This mouse nurtured poor nutrition during pregnancy, but after delivery, this mouse became very big, fat. And Barker's hypothesis, DOHAT hypothesis, was proved in animal, but people say that only Dutch farming showing the proof of Barker hypothesis, meaning that in World War II, German blockade cut off food and fuel shipments from farm town, and then that this kind of Nazis blockade induced Dutch famine, and then 22,000 may have died because of the famine, and pregnant women could eat only 2 pieces of bread and potatoes. And what happened for their babies in this era. And this guy was born in this era and then developed heart disease in later life in 26 years old and 44 years old. Due to time, I'm going to skip the video, but it's like this. Yeah, the situation was like this. Okay, so Professor Roseborn published the association between Dutch famine and greater prevalence of chronic heart disease. And those who have experienced the Dutch famine in early pregnancy, 3 times more likely to develop chronic heart disease. Okay, third point, trauma. So Judith Harmon, she is an American psychiatrist, and then she established the concept of PTSD actually. And then she said that lots of symptoms, psychological or mental health symptom occurred due to abuse, more specifically sexual abuse. And then her argument really shake the world, and lots of women confessed, I have sexual abuse. And this one linked with the women's new movement, then lots of people confess that. But this was really argued that trauma can be made up based on the current cognition. So meaning that even if they don't have experience of sexual abuse, if they have a really severe symptom, they can make up the past history. So there is some argument, but we think that she did a good job to develop the concept of PTSD. And then Bessel van der Kolk, based on Herman's work on the impact of trauma on the human body, actually. So during the treatment of veterans, he saw that the trauma memory or experience embedded within the body. Okay, so like if he or she experienced a trauma and then watch something similar to the trauma experience, the heartbeat occurs and try to avoid it. That is not a memory of a brain, but a memory of the body. So that kind of he developed that kind of conceptual model linking with the trauma and body. So this kind of a trauma theory really helps to understand the AS study. Okay, then Ron Kessler, professor at Harvard, did the World Mental Health Survey in WHO, and then he included the adverse child experience and categorized into 4 based on the attachment and trauma theory, actually. So one is interpersonal loss. This is absolutely loss of primary caregiver, attachment, parental die, divorce, as a parental loss. And second, family psychopathology. This is also similar to parental loss, but this not exactly the loss. And then this means that if the parent have some mental disease, they cannot provide enough care, parenting. Parent mental illness, substance use, criminal, and family violence. And abuse and neglect. This is trauma, actually. Physical, sexual abuse, and neglect. And other childhood adversity, having physical illness, that is why frequent admission or long hospitalization, that kind of stuff, or economic adversity. And people can argue that in a narrow sense of ACE, childhood poverty cannot be included, but in a broader sense, it should be included. It's arguable points. And McLaurin, the professor at Harvard, divided ACE into two concepts. One is deprivation, one is threat. It is quite reasonable. As we discussed, the deprivation is lack of attachment, lack of enough care, lack of nutrition. So lack of factors needed for development that induce a poor development of the brain. It's really reasonable. And threat as well. This is existence of factors which is threat to development, meaning that this kind of threat will activate the stress reaction HPA axis, then that kind of endocrinical response induce lower development of brain, like a lower volume hippocampus, amygdala, and the PMFC. I'm going to talk about it later. And so, and totally, this kind of theory finally explain why ACE affects on health. The answer is addiction. Those who experience ACE make people addicted to something, to for the, how to say, to in a response to the stressful situation. That is the way how to adapt circumstances. This addiction theories introduced by Professor Lebenthal at Yale University. So, and lots of association between ACE and poor lifestyle, like smoking, obesity, and alcohol, substance abuse, excessive sexual intercourse is all explained by addiction. And then actually, because of ACE, the brain development affected by poor development of regulated brain area which regulates something. Before that, let me introduce more about child abuse and obesity as an example. And this is already old study, but even in 10 years ago, there is a 41 study, and then there's a strong association between abuse and obesity, 1.4 ratio. And in this paper, they explain the association between abuse and obesity by 4 points. One is epigenetic, like thrifty phenotype, like as I explained, Doha theory. In stressful environment, there might be less chance to get the food. So in the genetic level, thrifty phenotype, meaning that to accumulate energy, is important to prepare for the shortage of nutrients. And brain structure. And as I said, I'm going to explain later, but this abuse affect on the control part of the brain. And stress reaction due to stress and HPA axis activated, that kind of endocrine effect on health that might induce obesity, and physiologically, and those who experience abuse feel fatigue and then less likely to do something. So, stay home, obese. Okay, so Professor Tomoda at the Fuku University in Japan, she did lots of a neuroimage study, and she showed that those who experienced harsh corporal punishment showed smaller medial prefrontal cortex MPFC volumes than those who didn't. So MPFC is important to prevent addiction, suicidal behavior, PTSD, dissociative disorder, and depression. All disorder are related to less control of their thoughts. So this is very important finding, meaning that those who experience of physical abuse are less likely to control their emotion. Okay, So last part is my unpublished paper, War as an Induction of AIDS. And as you know, now we are facing the very critical time, facing of just before maybe World War III. But we need to learn something from what happened in the World War II. And this is the picture of Japanese military. And then during World War II, most of the adult male sent to the war in Japan. And I must apologize what Japanese government did in Korea as a citizen of Japan. And then, we have to, learn what happened. And we need to prevent this kind of things never happen. And then this is the one, one thought how war is bad for next generation. And fathers, if they go to the war and return, they bring what they have thought in what they have seen in what they have did during the war, and then meaning that they might bring the violence in the home, and then they might abuse their children, they might beat their wives. Then that kind of things may induce poor health in their older age, like current older people in Japan. And what happened if a father went to the war during World War II and died? That induced parental loss. But because the father passed away, they cannot bring what they have seen at home. There might be some difference. Then I investigated both those who have experienced military conscription and paternal war deaths. This clearly showing that those who have been to the war and coming back, then the children in a later life, in the older age, more likely to show poor health. But if their fathers pass away in the war, even if they might experience parental loss, they didn't show poor health compared to those whose father didn't go to the war. That means that the war bring the violence concept, bring the home, then deteriorate the health of children, even in later life. Then I calculated how much percent of this kind of childhood abuse experience association between parental military conscription and the poor health. And this is up to 7%, not much, but there is significant path through the mediation effect of this kind of adverse experience between the association between parental military conscription and poor health. But for the war deaths during parental deaths during the World War II did not contribute to the poor health. Okay, so before conclusion, I'd like to share a good story. I hope social capital can mitigate the impact of AIDS on dementia. Then actually is those who are living in a high social capital area or rich social network environment, the effect of AIDS on dementia disappeared. So this is a good news. Even if people experience the AIDS, we can mitigate the impact on dementia by later social environment. Okay, so in conclusion, AIDS matters for health, not only middle age, but until older age. It's last very long. The brain damage due to deprivation or threat may explain the mechanism. And a war might be induction of ACE or violence, and which deteriorate the health of next generation. So, and then lastly, social capital can mitigate the impact of ACE on health. All right. They are my kids. Okay, thank you. This is the
Thank you very much, Dr. Fujiwara.
Yes.
This is a really great talk, and I personally learned a lot, and I think your presentation on this topic is very much helpful for the Korean audience,
Thank you.
particularly people in the Society of Preventive Medicine. So yeah, that is a really great story and great talk, but also it's I think a very much challenging issue to understand and to resolve. Thank you very much again. Is there any questions or comments on his talk from the audience?
If I may.
Okay, please.
Thank you, Professor Fujiwara. My name is Connie Park. I'm
Hi.
working at one of the provincial health bureau in Korea. Thanks for your great presentation, including not only your study, but also others very important study in relation to the childhood abuse. Maybe my question, you have actually, at the last of your presentation, you mentioned about some of the mitigation plans, such as social capital. So according to your presentation, there's several theories, for example, attachment theory, Doha theory, and trauma theory, and others. So according to the theory, we may also plan for how to, prevent the effect of the childhood abuse. So definitely the first prevention would be try not to happen that kind of bad things. But once things happen, then we also need to intervene to prevent further, health impact of this abuse. So if you can give some other, the stories about the interventions, how to, prevent this health adverse outcome after this abuse, it will be great. Thank you.
Sorry. So.
In addition to social capital,
other
that would be the good intervention. For example, I also read some neurofeedback, in these kind of things.
So if that might be related to severity of ACE, and then if people suffer from some PTSD or something, in some psychiatric intervention like neurofeedback or trauma-informed care, that kind of a treatment is needed. But as you can see, I would say like 30% of people suffer from at least some ACE. So in how do you say, weak having a weaker ACE, there might be some population approach might be effective. So social capital is one example, but and I totally agree that there is some psychological intervention might happen. And then actually recently we did some randomized control trial to deliver how do you say, some big doll, and then with the which can insert some smartphone, then saying something. And that really helped people, let the people to sleep. And that can be, we ask them to do it before sleep, and better sleep, I hope, induce better health. And then that kind of intervention affect only for those who have a lower score of ACE, and those who have a higher score ACE, it doesn't work. That means that you as you said, that more specific intervention is needed. So, you know, I think that the preventive medicine epidemiologist saying that like average intervention, but recently we need to do more on we need to care individual like heterogeneity intervention, tailor-made intervention might be needed.
Thank you very much.
Okay, I'd like to another question and comments. So if there is no further question or comments, I myself would like to give you a question. It's okay?
Yeah.
Dr. Fujiwara. So you talked about the intervention, and that the intervention level may be different depending on the number of ACs. But if there is such an intervention really depends on the number of AC, we should know number of ACs in the people who have obesity or diabetes or any health risk. So that means we should explore the past experience, the childhood, when we see the patient with the hypertension, the disease. So do you think we should explore child experience when we see the patient with chronic disease?
Yes, actually that happened in the US. They trying to ask the number of ACE in outpatient, clinical setting, and try to intervene something. And I myself try to do it in Japan, but there is huge barrier to do it in outpatient, meaning that middle-aged men who are diagnosed having a hypertension in the office, then coming to the clinic and the doctor asking what happened in your childhood.
Right.
It's really difficult. So, but, I think, but for some very difficult to treat patient, in such a case, prescribed drug, then they may not change weight, blood pressure, that kind of stuff. Then, we treat it using lots of drugs, but not effective. And then they may not take a drug every day. In that kind of a case, what happened? Well, we should discuss more. In that case, we can bring this kind of evidence into epidemiological evidence into clinical usage. Thank you very much.
Yeah, right. I really believe we need to ask the people about the past experience, but I'm also very much afraid they could be embarrassed when we ask childhood adverse the experience when we see just chronic patients. So, but that is also a challenging issue. We need to, I think that we need to really deepen our knowledge about this, and I strongly believe that we need to collaborate Japan and Korea about this area. I think this is an area very much important and emerging. So thank you very much for your contribution and your great talk. So I hope we see each other in person soon. So.
I hope so.
Okay. Yeah, and also want to collaborate Japan society and Korean society about contribution to the world in the health area. So
let's talk more on the contribution. Collaboration.
Right.
Great.
Thank you very much again, and I'd like to close this session.
Okay.
Thank you.
Bye.
Bye.
Hope to see you.
Thank you.